So I want to just take a couple of minutes and go through, refresh your memory about the nephron and how that works before we get into talking about the diuretics. Because the diuretics have action on the nephron, obviously, and some of them act in different places. So remember, the nephron is the functional unit of the kidney. It includes all the vasculature that goes around it, which is important for exchanging fluids and electrolytes and waste products and all sorts of other jazz. And then it also has the collecting system, which collects the filtrate. So the way this works is an arterial blood supply comes to the afferent arteriole. A means before. In the old days, they used to write before shorthand by making a little a and putting a line above it. Maybe you've seen that. Post or after was a P with a little line above it. I miss those days. I loved all those little abbreviations. But now we have computers. All right, anyway, the afferent, or before the glomerulus arteriole, goes to the glomerulus, and there it essentially dumps the plasma. I mean, it's really plasma minus a whole bunch of big proteins that just gets dumped directly into the glomerulus. And now that becomes the filtrate. And as that filtrate moves through here, it goes through the proximal convoluted tubule. That makes sense, right? It's proximal to the glomerulus. It's convoluted, and it's a tube. So that's the proximal convoluted tubule. And then it goes down to the descending loop of Henle. And then it comes up the ascending loop of Henle. And then finally, it progresses through the distal convoluted tubule. Also makes sense, until it gets to the collecting duct or the collecting tubule. Now, what makes up all these vessels that surround all of the collecting duct and the microtubules or the nephron tubules? Well, it's the artery that came from the glomerulus. So we call this the efferent arteriole. And the efferent arteriole then starts wrapping around all of the nephron, along with the vein wrapping around all of the nephron. And that's where the fluid and electrolyte and other stuff is exchanged. It is a fascinating work of genius. All right. We enjoy the work of genius in the pharmacology world because we can target specific areas. We know what happens in the proximal tubule. We know that potassium is recovered there and sodium is excreted there. And we know all that stuff, so we can use that knowledge to develop drugs that do exactly what we want, where we want. So for instance, in the proximal tubule, you'll see that's a good place for osmotic diuretics to work, which we're going to talk about later. But it also is a good place for the carbonic anhydrase inhibitors to work. Those are two drugs that we don't use very much, so we're not going to talk too much about the proximal tubule stuff. But we are going to talk about loop diuretics. Guess where they work? That's right, the loop of Henle. And thiazide diuretics are the blood pressure medicines that we use so often in clinical practice. Hydrochlorothiazide being one of them, chlorthalidone another, indapamide, some of those. But HCTZ or hydrochlorothiazide is the one that you're going to hear about most often. And then finally is these drugs that I hate this name, but we call them the potassium-sparing diuretics. And that means they allow the resorption of more and more potassium before it disappears. Okay, so we're going to talk about that, and we're going to talk about why I don't like the term potassium-sparing diuretics.